So essentially, like he mentioned, there are 4 valves in the heart, and right now all those 4 valves, which is aortic, mitral, tricuspid, pulmonary, can be placed percutaneously without having a cut open chest. But what I'm going to focus today is aortic valve as well as the mitral valve. What are the intervention we can do percutaneously? Just to give you a little background on aortic valve disease, we all know normal is about 3 to 4 centimeters squared, and severe is less than 1, and the critical is 0.7. So other than congenital, acquired, I think this is where we need to focus, because this is what we see, calcific, especially because of hypercholesterolemia as well as calcium. But if you see, what is the incidence? 5%, 10%, and by the age of 90, close to 20% of the patients could have had this disease. And we all know the Braunwald description that once they have symptoms, then their survival is very poor with aortic stenosis. So what has been the guidelines? As per the guidelines, surgery has been the standard of treatment. Why? Patients live longer, feels better, and more important, LV function improvement if there is mild LV dysfunction. So how did the percutaneous come into existence? The father of percutaneous heart valve therapy was Alain Cribier, where he did his first case on April 16, 2002, and subsequently the publication saying that non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and mid-term hemodynamic and clinical improvement. This is the first patient that got that valve. So coming to TAVR, most important, because in the past, what used to happen if somebody has aortic stenosis as diagnosed by stethoscope, what people would then send the patient for cardiac cath. But with the advent of percutaneous therapy, things are changing. Diagnosis is made by echocardiography, and then what we need to do is also have what is called as a CT scan, which actually is going to help us to tell us what is the kind of valve sizing, and can they have, what's the kind of the route for the placement of the valve. So what is based on imaging on echo, severe AS is here what we have to, you have a mean more than 40 millimeters of mercury. That is why I think you can hear every time you're calling us, referring for patients, we always ask, is there an echo? If not, when you refer a case to us, we will do an echocardiogram. So these are the criteria, which is like you have a mean of 40. That is the criteria for us to say, yes, that this patient will then meet the criteria for aortic valve. Then the second step is that every patient will have what is called as a STS risk calculator based on their age, gender, and various risk factors that they have. This is an online risk calculator. Why this is important? Because this is what the surgeon will depend on. This is how the trials were done, that more than 50, the STS score, that means they are too sick, usually would be a palliative care for this patient. More than 15 were extreme risk, about 20% of the patient. And then high risk, about 10 to 15 would be a STS score, but intermediate risk was 4 to 10, and STS score of less than 3 were low risk patients. Well, how did TAVR come into existence? We started with extreme risk trials, then we did intermediate and up to the low risk. So these are the trials that I'm going to go over. And there are 2 FDA approved valves. One is the SAPIEN, other one is the core valve, which is Evolute. These are the various routes that usually a percutaneous valve can be placed, but the most common is femoral, subclavian, and now even transcarotid valves are being done, but these are the most common approaches. So the first trial was a partner cohort B, which was same extreme risk, what I showed you more than 15%, and what it showed that compared to standard therapy, where patients had just medical therapy when the diagnosis of aortic stenosis happened, if they had TAVR, there was a 20% reduction. Subsequently, the core valve did a trial. Since there was a benefit, they did not have the arm of standard therapy. Everybody got the valve, and the FDA approved the valve first 2011 for the SAPIEN valve, and the core valve 2013 for the patient who are extreme risk cases. Then was a partner cohort A, which was for the intermediate risk, similarly was for the core valve, which was for the high risk, which showed both surgery as well as TAVR were equal, except in the partner trial, there was a slightly higher incidence of a stroke rate with the TAVR compared to SAVR, but subsequent trials did not show that. And then it was approved at 2014. Now, then was the intermediate risk that came, where was partner 2A trial, and the CERTAVI trial was done for the core valve. Again, SAVR versus TAVR, both were equal. FDA approved for intermediate risk between 2015 and 16. 15 was same for the SAPIEN, and this was for the core valve. So then what happened is that definitely for extreme risk and high risk, by then there was already TAVR. And this is, I just wanted to show you a case of, that means by then the intermediate risk was already approved. So this is a 74-year-old female, 2016, NYHA class 3. Some risk factors here, if you see, and then was on good medical therapy. Non-obstructive coronary artery disease on her angiogram. This was an echo. You see here significant aortic stenosis with a mean gradient of close to 50 millimeters of mercury. Now, if you see here, STS score was 2.1. So what happens? The surgeons see the patient. At that time, the low-risk trial was ongoing, and the patient got randomized to the TAVR. So what we normally do is get a balloon angioplasty, balloon valvuloplasty first, and this is the core valve. If you see here, always we make sure we are starting at the right position, and this is how we gradually release the valve, and once we know that it's at the right position, then we completely release the valve, and very mild AI. Because there was some AI, we did a post-bar dilation, and this is after that AI is gone. But what you can see is that the coronary arteries, you can still see a good filling from that. So patient did well, went home 48 hours later on clopidogrel only because no aspirin. GI bleed, will discuss this, what should be given to the patients, and has been seen subsequently doing well and only has been on clopidogrel and atorvastatin. In this patient, we continued clopidogrel because there was history of CAD. So if the question comes, okay, you have done the TAVR, and surgery we know has been the gold standard, has been done for many years. So this is a 5-year follow-up. This is the mean gradient in this patient. If you see here, your valve area is about 1.5, which is excellent, much better than the standard surgical valve. So for low risk, more trials have happened. So 2 trials in the US were completed, which was Partner 3 and Evolute, which were presented this year during the ACC, and the other trial was a Notion trial, which actually has been ongoing. If you see here, this is a Notion trial, which was SAVR versus TAVR, about 280 patients. What you see here is, for the low-risk patient, everything is equal, no significant difference, except slightly higher pacemaker rate in this group of patients. And this is the clinical outcome at 5 years. Other than the pacemaker, no difference, TAVR versus SAVR. So why low risk came into existence is having had all the high risk, intermediate risk TAVR having done. So Partner 3 study, what was it? Is a low risk patient were randomized to TAVR versus SAVR, but what the TAVR had to be done only via the femoral route in this particular case after the heart team discussion. So if you see here, the first trial to show that actually TAVR was superior to surgery. And what was important is that no difference again in any of these outcomes, and the length of stay was significantly lower in the TAVR patients compared to the SAVR group. And one thing was for sure, people who went for surgery had some higher incidence of AFib. This was the core valve, similar design, TAVR versus SAVR, and then they had a sub-study to check what happened to the leaflet, heart team discussion. It is very intense when these studies are being happening, that you have to do echo, CT scan, upload them, then there is a screening committee, and the heart team evaluation happens locally. When everybody has decided that this is the right patient, then only the patient gets randomized to TAVR versus SAVR. a similar outcome, and look at the length of stay. That patients go home less than 3 days compared to surgery. They stay for longer. But as we have shown, that always TAVR has slightly higher pacemaker rate compared to surgery. So based on that, this was the New England Journal paper that came out with a simultaneous publication, and this was the New York Times, which said that FDA approved TAVR for low-risk aortic stenosis, and this happened July of 2019, which you probably have heard from us right now, that even the low-risk patients will be getting TAVR. So it is relatively, what are the potential complications of the TAVR, if you think, which is, most of them are very rare, but one thing that we have to, everybody gets worried, is about stroke and TIA, and of course, valve degeneration. Although I have showed that there is data up to 5 years that valve works well, I'm going to discuss a little bit about valve degeneration. Now, stroke TIA, since these patients are elderly, not the low risk, even the high risk and intermediate risk, when we are going through the aorta, definitely it is atherosclerotic aorta, the risk of stroke is less than 2%, and guess what? Interventionalists, if there is one problem, they'll find a device. If that device does not work, some other device. So these are the various reasons why we can have this. Either it's embolized from this aortic valve or from the arch when we are going through when you are getting the valve across. So these are the devices that were actually tried, but right now Claret Sentinel device is the one that was been FDA approved based on this particular trial. What it showed, those not statistically different, lower stroke in the treatment arm compared to the control arm in that one trial. So every patient will be screened. They need to have a good radial artery so that we can go from the right radial and place this Sentinel device in both the carotids before we do the procedure. And this is just to show SAPIEN versus core valve. They, like any other device, a lot of generations have changed. This is the current generation essentially saying that these valves are better. And the next point is, can this be used in bicuspid aortic stenosis also? What's the difference in bicuspid versus a tricuspid aortic stenosis with early and new generation device? Same, that it can be used in bicuspid valve with a good result, with no difference whether it is bicuspid or whether it is a tricuspid valve. Other than common scenario, which is a rare scenario that we see, but often I would say about 20% of the patients that are referred to us, one is paradoxical, where your EF is low. Other one is low flow, low gradient, where you have a normal EF, but since LV cavity is small, that you have AS, but your gradient is low. So would these patients benefit from TAVR? So there was one trial called as a Topaz-Stavy trial that actually was published in JACC. If you see here, what they did was definite. The mean EF was about 30% and a gradient about 25 or so. And many of these patients did undergo dobutamine stress to see what the gradient was. And this was that beautiful central figure, which is just showing that presence of contractile reserve or no presence of contractile reserve. The original data was that if you go for surgery and you had a presence of contractile reserve, they did better with the mortality benefit. But if they did not have contractile reserve, they did poorly when they went for surgery. But with TAVR, both the arms, with whether they had contractile reserve or no contractile reserve, they did well, essentially saying that TAVR is doable for this kind of patients. This is another one that we are saying that TAVR can be done for valve in valve. That means they already have had a prior prosthetic valve. And can you do a TAVR? The prior prosthetic surgical valve, can you do a TAVR in those particular valve, both whether it is SAPIEN or Medtronic core valve, saying that actually TAVR probably was better, and they compared it to native TAVR, saying that yes, it can be done. So this is just another case where I'm showing this is a bioprosthetic AVR, and had a whether it is restenosis or sometimes they always come some AI also. So this is a SAPIEN valve in place. This is the second valve that we are placing. And the SAPIEN one, the one I showed earlier was self-expanding, but this is a balloon expanding valve. So this is the TAVR valve there, and which is with the balloon. Once you expand with the balloon and then you deflate the balloon, you will see that the TAVR valve stays there. So you can now appreciate the original native valve, the bioprosthetic valve, and now the stent frame of the new TAVR valve. So subclinical leaflet thrombosis became a big issue. This is the same concern. Why does it happen? Is it because they are not on anticoagulation, or is it because of some damage we create with the balloon, whether when we are placing the valve, or because of the balloon valvuloplasty we are doing subsequently later to prevent paravalvular leak? This is the CT scan, what they do. We can be followed up. So you see some leaflet thickening. So essentially, if you see there, what this study showed that came out in the Lancet was anticoagulation will reduce leaflet, but there is studies also shown, which is actually Galileo, this is presented sometime later this year, saying that patients who there was no difference, more important also that there was a higher incidence of bleeding in this group of patients, so much so the study had to be halted. So at this time, we just have to carefully monitor these patients. They will get an echo at 1 month, and if there is any change in gradient, means normally the gradient should be less than 10 in any kind of this valve that we have placed. If the gradient is more than 10, we probably will ask them to come earlier than a year. Otherwise, it will be a yearly surveillance where we will do an echo here at Mount Sinai. And also other thing always comes is this TAVR patients do have concomitant coronary artery disease. So what will happen to them? If we see coronary artery disease, should we take care of the coronary artery disease? So this is a CERTAVI trial where you see patients were assigned, if they had TAVR, they were assigned to PCI. If they had SAVR, they were assigned to CABG. There was no difference. So if you are doing TAVR, and if there is significant coronary artery disease, you can take care of the coronary artery disease before the TAVR. So when I'm saying significant, we are talking epicardial vessel of more than 80% lesion. Anything less than 50%, we can leave it alone. This is the publication from our group that came out in JACC last year, that coronary angiography and PCI after TAVR. Why we should pay attention to the coronary artery disease before and take care of them? One, they, of course, during the procedure for about 30-40 seconds, we will have no cardiac output while we pace the patients. But subsequently, engagement of coronary arteries through this nitinol cage is very challenging. So this was the article that we published saying what are the catheter selections for the patients who have had TAVR, and that is also made an app called as TAVR Cathate. So we made some beautiful animations that is showing you how exactly you should be dealing with this catheter placement, that you got to be very cautious how you are entering this TAVR valve and how you're going to engage it through the right diamond to enter into the coronary artery and to do coronary angiography. So that is the core valve. This is the SAPIEN valve. What we also created is an website right now for all the apps that Mount Sinai Cath Lab has made, which I will go over a little bit later. These are all the apps that are available. Anybody wants to, you can download it from the App Store or Google Play. It's all free. So outcomes of Mount Sinai Cath Lab TAVR for 2018, if you see, just 50% of SAPIEN valve and 49% core valve. So if you see here, you'll be asking what kind of sedation, because these patients will be probably asking you these questions, or when they come to see us, is 75% conscious sedation. Anesthesia are involved, but when they are in the room, they just give some sedation, and very rare, 25% will be GA. So if you see, close to 90% is a perc femoral, about 10% cut down, and very rarely we do subclavian. If you see, the TVT registry is a registry of the entire, which ACC maintains it, and our data compared to TVT registry, we definitely have, if you see, it's all comparable. And coming to the choice of TAVR for TAVR versus surgical VAR in the AVR patient, I think I've made it very clear that most patient, which is prohibitive surgical risk, high surgical risk, intermediate surgical risk based on the guidelines. Everybody can get TAVR. Only thing low risk on the guideline was supposed to be surgical AVR, but with the recent trial that just came out, even the low risk right now would be TAVR. So the final question would be, this is the projection, what you see here, annual TAVR procedures in USA. The projected will be about 60,000 procedures here, TAVR growth. So the question is, who are the patients should be referred for surgery? So low to intermediate STS risk and extensive coronary artery disease. So like I mentioned, if you think there is a 3 vessel with significant coronary artery disease, those patients definitely should be considered and probably better that should go for surgery. And bicuspid AV with the low STS risk, because right now bicuspid AV is on the registry and a trial has not been FDA approved yet. Young age with the issue of future valve degeneration, but if you see there's concomitant aortic root dilation and needs aortic root surgery, that patient should go for surgery. And very rare, we will see a case where there's a lot of calcium, especially in the LVOT, there's a risk of rupture when we do this TAVR. And there is a low to intermediate risk patient with a bioprosthetic dysfunction. If you have a 50-year-old or with a bioprosthetic valve, maybe you should consider second surgery rather than do TAVR. And very important is adverse anatomy, that you have a low-lying coronary height. Based on the CT scan, which is important, we also will get the height of the coronary artery, that when we do TAVR, there's a risk of occlusion of the left main. If that is something we think is there and the patient is low risk, those patients definitely should go for surgery. And of course, if there's concomitant other valve disease, this kind of with low risk should be considered for surgery. Moving on to MitraClip, that is MitraClip for all functional mitral regurgitation. That is something, let us figure it out. So total patients with mitral regurgitation, about 4.1 million. Eligible for treatment with grade 3 plus is about 1.7, and the annual incidence, if you see here, is about 250. But more important is MV surgery, only 30,000 per year. So only 2% treated. So there's a large group of patients who are not being treated, probably need something done to these patients. And we all know how mitral regurgitation works, that mitral regurgitation begets mitral regurgitation in the sense that it increases LV strain, LV dysfunction, more MR, and thus increases mortality. And also, we know that MR and heart failure, there is moderate to severe MR in patients with heart failure. About 40% of the patients do have concomitant mitral regurgitation of some severe degree, and about 5 million patients are there with heart failure in US. So there are 2 classifications of mitral regurgitation. One is primary. Primary means there is something wrong with the anatomy of the valve, which is usually prolapse. That's all we finally, but then it could be subvalvular apparatus or problem with the papillary muscle. But what we mainly deal with is the leaflet prolapse. And the second one is secondary. Here the LV function will be normal. Secondary, you have LV dilation for whatever reason it is, and that LV dilation give rise to mitral regurgitation, and that is the secondary MR. So what is the guideline right now? Management of mitral regurgitation, if you see here, first you identify, define what is the cause of mitral regurgitation, and assessment has to be done by the imaging, and most of it is echo, which is transthoracic, or TE. But if you go to treatment, if you see here, it is just a teamwork where a lot of people are involved in managing these patients. But essentially what you need to do is make sure that they are on good medical therapy and lifestyle modification for these patients. And here it comes that if the surgeons think the patient is prohibitive risk for surgery, that's the time those patients should be referred for MitraClip. But the key is follow-up. Just because they got MitraClip or just because they got surgery does not mean that they should not continue what is called as guided medical therapy, management of hypertension, AFib, CAD. All these things have to continue. So This is the important thing that you need to know for management of mitral regurgitation. So current therapy is the same, medical therapy. Everybody has to be on medical therapy, especially if it is primary MR. And you have what is called surgery, but what I'll be discussing is maybe less invasive procedure, which will be MitraClip, which is a venous procedure. And you will see this animation right here. It is a large sheath that will be going from the vein, and you do a transeptal procedure. You have to go from the right side to the left side. This is a sheath that will go into the left atrium, and this is, you see the clip. And this clip, the same thing, there are various knobs where you can go anterior, posterior, medial, lateral, and this, like most procedure where interventionalists do it under fluoroscopy, this procedure is guided by the echocardiographer. So you have a TE and echocardiographer with you telling us where to do the transeptal. The key part of the MitraClip procedure is to have the right transeptal so that then your navigation of the whole device and placement of the clip becomes very easy. So if you're not happy, again it can be released and place it in the right place where you know the right part of the leaflet has been clipped so that the mitral regurgitation goes down. So the first trial that was done, randomized other than the non-randomized trial, was Everest 2. Device was to control, same 2:1, and the patients were followed for 30 days, 6 months, 1 year, up to 5 years. And what it showed, any device that comes out, first and foremost is it safe and effective? So same, definitely it was very safe. Venous procedure, compared to arterial procedure where like TAVR, where we showed there is a risk of stroke and all that's unlikely, but effectiveness is same. The therapy for mitral regurgitation, which is surgery, compared to that was okay. So based on this trial, what happened is there was a New England Journal publication showing that although percutaneous repair was less effective in reducing mitral regurgitation than conventional surgery, was associated with superior safety and similar improvements in clinical outcome that left to the FDA approval for the degenerated or primary MR. Right now, we have the FDA approval only for the primary MR to do the clip. So this is a 79-year-old female who had a EF of 25%. And what happens is, I would say about 15% of the patients would have mixed, where they have a prolapse as well as dilated LV. So this patient actually belonged to that group where she was mixed. So if you see here, severe mitral regurgitation, this is a 2D echo. This will be the 3D, where you can see a nice prolapse also on the 3D echo. But more important, we can do simultaneous measurement of the V waves in this group of patients, and V waves were almost 80 in this patient. So first clip was placed. I'm not sure if you can see it very well here, but at least here you can see that the clip is in position. But then what happened, from 80 it came down to 50. Still you can see prolapse on either side of the clip. And what happens is, once you have released, or before you release, you also have to make sure the gradient across the mitral valve is not significant. So it should not be more than 7 or 8 millimeters of mercury. So this was low, so we proceeded with the second clip, which was placed. After the second clip placement came down to like 40, and then we actually went to the third clip. If you can see, you have 1, 2, and a third clip placement here. After that, we brought the V wave down to almost 25 or so, and regurgitation, which is severe, came down to mild. So this is what you will see, how the clips will look like. So the TE probe there, these are the 3 clips. So this is the X-ray, where I think with many people may not be aware of. Everybody knows a pacemaker, a AICD lead, how it looks like. But if you see something like this, it is a mitral clip that we have placed. So this is end result. Case 2 is another patient. If you see, these are the patients who are multiple comorbidities on good medical therapy, which would include Lasix, ACE inhibitor, beta blocker, and then they continue to have heart failure. These are the kind of patients they are referred to us. So if you see here, same big V waves close to 25 on medical therapy, and nice prolapse. Look at the MR, significant MR. And this is a clip in the 3D, and reduction of mitral regurgitation. You barely see what I say. No RBCs are going back to left ventricle now with, look at your V waves down to 5. This is a single clip there. This is just to show you the end result. Severe MR to mild MR, or probably minimal. So, like I mentioned, how would you do the transeptal procedure, and how to do the clip and transeptal procedure also important if you are doing other mitral percutaneous procedure. We have an app for that. Again, you can check that. It's free to download from the App Store or the Google. This is what we have done. You see the hybrid images where this is X-ray, this is how the echo will play, and we have various animation to help you how to do the transeptal. Actually, there's a video that will show how a transeptal procedure can be done, step by step. So when actually you're doing a transeptal procedure, like I was showing you, what you need to know is that the height from where you're measuring where transeptal is key. This is how the echocardiographer will tell us. Are we at, you got to be posterior and high. Your height should be 4 centimeters or above, so that you will then be able to navigate your clip. If you're very low, the clip will be difficult to reach the mitral annulus. You need to be posterior and higher. That is why this is the key I told you is the transeptal procedure. This is the most important trial that was presented last year during a TCT, a randomized trial, whether standard of care versus clip would work for patients with secondary MR. So that was the background, where we know for patients with dilated LV and MR who have in heart failure that surgery is not the treatment. But more important is guideline directed medical therapy or CRT had to be done on these patients, and despite that, if they had symptoms, they were the one randomized. So it's key that everybody knows that patients with heart failure and mitral regurgitation have to be on full medical therapy and symptomatic on therapy and have MR. Because what happens, I would say about 60% of this patient, when you give them some kind of therapy, the mitral regurgitation disappears. So if they have symptoms on therapy, they are the one they were randomized to mitral clip along with therapy versus guideline directed medical therapy. So this is how they were randomized, about 300 in each group. And if you see here, most of things in both the arms was equal. But very important is the risk group of this patient: diabetes, hypertension, prior MI, prior CABG, TIA, and then look at the heart failure. Look at their BNP, 5,000. So they were sick patients when they were randomized. And STS score, I told you just about 8 or so. These were high-risk patients who were then randomized to medical therapy. And CRT, about 1/3 of the patients were on CRT. So the medications that they were used were beta blocker, ACE inhibitor, mineralocorticoids, but more important, diuretics. Everybody had to be on diuretics. So multiple or 1 or 2 of these medications had to be there. And patients were compliant. This is the reason why we are showing this slide, saying that most people were compliant, that there was not that they were started and did not continue on medication. So the clip procedure, if you see, was successful, 97% successful clip. And also if you see here, more than 95% of the patient had less than 2+ MR when the clip was placed. And the number of clips, if you see, 1 clip, or majority of them got 2 clips. 1 patient got 4 clips. So what was the primary endpoint? All hospitalization for heart failure within 24 months, which was significantly lower, as well as more important is the first time the trial showed that these patients actually had mortality benefit compared to standard therapy, which was just medical therapy here, which was significant. And this death or any kind of heart failure hospitalization also was better when patient got clip compared to just medical therapy. So what they concluded that in patients with heart failure and moderate to severe mitral regurgitation on therapy, MitraClip is safe, reduces hospitalization, improves survival and quality of life. So is first-line therapy to improve prognosis in patients with heart failure secondary to LV dysfunction and secondary MR. Now, going on to that, there is a group of patients who could benefit from not clip, but for whatever reason that they could benefit from valve placement on the mitral area. But who are they? Patients who have calcific mitral annular calcification, which is called native MAC. If they already have a valve, mitral position, or they had a repair with a ring. So this was a trial that was presented in 2017, and subsequently you'll see the results of these patients. So essentially, I think if you think at the valve-in-valve patients, which is previous prosthetic mitral valve, they actually did better compared to valve in MAC versus valve in ring in this group of patients. So if you see the survival, all-cause mortality at 1 year, if you see valve in valve, which is in green, was okay, but the valve in MAC survival was very bad. So essentially we are saying that valve in MAC, which is native calcific mitral annular calcification, is not a good treatment. So just to show you a case, again, 77-year-old lady, multiple comorbidities, who had a 25 millimeter Hancock prosthetic mitral valve, with heart failure, and was not a candidate for surgery. So this is how this is, you see this, the prosthetic valve, and there's a degeneration and some regurgitation in her. So she had a gradient of 19 millimeters of mercury across that valve. So how do we do this procedure? We will do transeptal, and see this stiff wire across, and we'll go into, this is the mitral prosthetic valve that you would see here. So now we are inflating the sapien valve in the mitral area. It was fully inflated. This is how it looks at the end. So the gradient reduced from 19 to 7, and this is the leaflet of the newly placed sapien valve on the mitral area. This is the pre, and now you see the new valve, 3D echo. So essentially what we are saying is that it is a good treatment for patients with valve-in-valve. So just for conclusion of the mitral, that MitraClip results in clinically significant MR reduction in majority of the patient. It is safer than surgery, and MitraClip results in similar patient-centered outcome to surgery, including improvement in heart failure and quality life and reduction in readmission. So it is ideal for poor surgical candidate with appropriate anatomy. So what we request is these patients will be seen here, heart team, which includes interventional cardiologist and a senior surgeon that will see the patient together. And when we say appropriate anatomy, means these guys need a protocol-driven TE done here, so that we know that we can do a nice transeptal, and we need to understand how the mechanism of mitral regurgitation, and is there enough leaflet for us to grasp when we are doing the clip. So that TE is to be essentially done by us here in Mount Sinai. Is now FDA approved for patient with the degenerative etiology. The one co-op trial that I showed you, we still do not have the FDA approval, which should be happening in the next couple of months, which means that patients with secondary MR also could be suitable for MitraClip. TMVR device for native disease have potential, but has a long way to go. But TMVR used for sapien valve has been recently approved by FDA for bioprosthetic mitral valve degeneration. So if this is very important, that if they have a prior mitral bioprosthetic valve and there's a degeneration, then SAPIEN valve has been FDA approved. This is the live cases that we do as much as a teaching institution we are. We have done it for PCI for the last 10 years, and we do structural, which is every other month, second Tuesday at 9 a.m. So most of these are archived. If you go to ccclivecases.org, any of the things that you will have a didactic discussion with a lecture by Dr. Sharma, then we go over the case. So, during your free time, you can watch it, archived cases. They are also available on the YouTube where you can, learn many of this, at least understand what these procedures are, where the discussions are happening. Now, this, since it is worldwide, so the total page views are over 1 million now. And what we just recently did is all the apps that we are doing. We have a website that we have created, very simple, cardiologyapps.com, and all these apps that we have created can be downloaded for free. Thank you for your attention. For primary, you don't have to be on therapy. I think primary, if the surgeon says patient has a prohibitive risk, they can go directly to clip. But for secondary MR, definitely who are in heart failure with LV dysfunction, we got to make sure that they are on guided medical therapy, which I think all the drugs that I've mentioned, at least 2 of them, they have to be on that, and still on heart failure, and we demonstrate that they have mitral regurgitation, then those patients with suitable anatomy will get clip.